Hello, I'm Dr. Dirk Arnold. I am director of the Department of Medical Oncology at the Klinik für Tumorbiologie in Freiburg, Germany. Welcome to this activity on treating colorectal cancer with anti-angiogenesis agents, where I will be using a patient case to share evidence-based practices that I hope will help you to provide outstanding clinical care to your patients. So, I'd like to present you a patient case of a 60-year-old patient of mine who was a 60-year-old woman, former teacher, single, and she had a very active lifestyle, enjoyed hiking and exercising, etc. However, she developed constipation, and after about 3 months of constipation and some weight loss for about 5 months, she presented at my office. We undertook a physical examination. She was in perfect health. She had a good performance status. Her body mass index showed normal weight. She also had normal cardiovascular function. By the laboratory results, there was a slightly elevated CEA, and that brought us to the use of colonoscopy, and their mass was found in the sigmoid colon, which was biopsied, and the biopsy revealed this to be adenocarcinoma. Further diagnosis on CAT scanning of thorax and abdomen showed no distant metastases. So, of course, the treatment of choice was surgical treatment. She underwent hemicolectomy, and the pathology confirmed the biopsy, saying it is adenocarcinoma, moderately differentiated. Of course, she underwent a resection, and in this specimen, 3 out of 8 lymph nodes were positive, so she had a PT3 and 1 disease. However, postoperative CA was slightly elevated with 90 milligrams per milliliter, and we thought this to be a result of the preoperative elevation. And as she was stage 3 disease, we recommended her to undergo adjuvant treatment with FOLFOX or capecitabine oxaliplatin, but unfortunately she refused to undergo treatment. However, we kept her in close observation, and at the 6-month follow-up, which we did by CAT scan, we saw some enlarged lymph nodes intraperitoneally, and also some signals of peritoneal carcinomatosis with the enriched perigastric signaling. So this was highly suspicious of having developed peritoneal carcinomatosis. So by that moment, we reconsidered all the findings we had before, and also reconsidered the workup of the pathological testing, because we only knew from the primary tumor result that she was KRAS, meaning exon 2 wild type. And as it is standard, at least in Europe, to have the full RAS analysis before we make a treatment decision, we also undertook the analysis of the other KRAS genes and also NRAS genes. But in all of this, as well as the BRAF gene, she was wild type. She had wild type status. So this brought us to the situation of decision making. What should we give her as first-line treatment? In this situation, with an all wild type, any first-line treatment would be an option. Any chemotherapy for FOX or FOLFIRI with any monoclonal antibodies, so meaning either bevacizumab or any of the anti-EGF receptor antibodies. By weighing out the risk and benefits and also toxicity, the decision was made to give her FOLFOX plus bevacizumab as first-line treatment, and we started treatment after this workup. She had, fortunately, no symptomatic toxicity. After 3 months, meaning after 6 administration, she had developed a mild neuropathy, but lab results showed no high-grade toxicity. So we continued this treatment for further months, and after about 4 to 4.5 months of treatment with FOLFOX bevacizumab and the onset of mild neuropathy, we were redoing the staging and saw that she had some partial response. So the question which arose at this moment was, how should we continue our treatment here? Would it, with the development of the mild neuropathy, to continue with FOLFOX bevacizumab until the maximum response? Or would it be a better idea to continue with any fluoropyrimidine plus bevacizumab but without oxaliplatin, so meaning just leave out oxaliplatin and continue with the fluoropyrimidine plus bevacizumab alone. A further option would be to continue with bevacizumab or to consider no further treatment until progression, so meaning to stop all treatment, or at this moment to switch to FOLFIRI plus bevacizumab because the toxicity she was exposed to was oxaliplatin-based toxicity. So this is the question number one, and you can think about the right answer which you would give this patient. Our decision was to continue the treatment with fluoropyrimidine plus bevacizumab. In fact, we were continuing with 5-FU plus bevacizumab. What was the explanation for this, or what is the consideration behind? Well, the consideration behind is that we know from now 2 randomized phase 3 trials, the CAIRO-3 trial and the AI-002-07 trial, that continuing with an active maintenance treatment with the fluoropyrimidine plus bevacizumab gives the maximal benefit to the patient by improving progression-free survival and also impacting on overall survival, which was improved in both trials, but in both trials not statistically significant. However, the further approach in the near future may be to use other maintenance treatment in this situation, so meaning maybe in the future to substitute this de-escalation maintenance with the best treatment option of a fluoropyrimidine plus bevacizumab by any other innovative treatment. But that's, I think, the development of the near future. The current standard of care is to continue with any fluoropyrimidine plus bevacizumab to exploit the maximum out of the selected treatment strategy. So oxaliplatin was discontinued after 4.5 months of treatment and with partial response. And she continued with 5-FU leucovorin plus bevacizumab. After more than 7 months of further treatment, she had a nearly complete response by PET scan, so we saw no evidence of disease in this setting. And for the first moment, CA levels were completely within normal range. We continued treatment for 3 more months, summing up to a 15-month total treatment duration with 5.4 months of FOLFOX and then followed by 10.5 months of fluoropyrimidine plus bevacizumab, and then we discontinued treatment. However, nearly 4 to 5 months after discontinuation, so meaning after 19 months from initiation of treatment, she was slightly progressing. So she showed again some enlargement of the lymph nodes, which some growth. Also, the peritoneal mild carcinomatosis appeared again in the CAT scanning, and the CA again increased to 55 nanograms per milliliter. Neuropathy at this time point was nearly completely resolved, and this led us to question number 2, with this slight progress after now this 19 months of treatment, what would be now the best treatment option? There are several options. One option would be to restart the last successful maintenance treatment, which is 5-FU plus bevacizumab. Or it could be another option to reintroduce FOLFOX plus bevacizumab, so meaning using the full first-line treatment combination, because this was a very successful beginning of the treatment. Other options would be the second-line FOLFIRI, meaning changing of chemotherapy plus bevacizumab, so meaning following the TML-like strategy with the continuation of the anti-angiogenic strategy with another chemotherapy. Another treatment option would be to use FOLFIRI, but not with bevacizumab, but with any other VEGF compound. And we come to this in a minute, because we do have, in this situation, aflibercept, and in the near future, ramucirumab available in this situation. As she was pan-RAS wild type, of course, also the combination of FOLFIRI plus any anti-EGF receptor antibody may be a treatment option, and maybe there are some other ideas also. So this was the second point of treatment decision, and you can think about what would be your treatment of choice in this situation. Our answer was to continue with a real second-line treatment, meaning to switch from maintenance 5-FU leucovorin or from first-line FOLFOX to FOLFIRI, and our strategy was to continue with FOLFIRI plus bevacizumab because we found by the risk-benefit toxicity ratio, this should be a very good treatment option for her with her relatively indolent, non-aggressive disease. You can find some of the explanations why this was the selection of our choice also in the background resources. But I think treatment decision for second line is really a complex thing because we do have the same points of making treatment decision in second line as we do have in first line. So toxicity, efficacy, treatment goal, molecular information, etc., etc. But also by the moment of second-line treatment decision-making, we also do have to consider how successful our first-line treatment was and what toxicity was a kind of left over from the first-line treatment. And in her case, we had some concerns that reintroducing oxaliplatin may have worsened the neuropathy, and therefore the decision was to go to a FOLFIRI chemotherapy plus an anti-EGF receptor, plus an anti-VEGF compound. Why an anti-VEGF compound? Well, the answer is relatively clear. We have very convincing data that continuing in second line with an anti-angiogenic agent, either bevacizumab or aflibercept or ramucirumab, may increase overall survival. There are now 4 randomized phase 3 trials which have shown that overall survival is improved when we continue or use in second line an anti-VEGF compound, whichever of these. And as mentioned before, you find the results of this trial in the background resources. However, anti-EGF receptor antibodies also may be active in second line, but we know that they show a comparable treatment effect in first line, in second line, and in third line. So it can also be a good idea to use these drugs then in third line. So what was the story? We continued with FOLFIRI bevacizumab as a real second-line treatment for more than 5 months. Initially, she responded. She had, again, minor response. But then, after nearly half a year of second-line treatment, she developed 4 new lung lesions. She was, again, in excellent performance status, had no neuropathy from fatigue, and we saw that CA was increased again. So this was a clear progression, a clear failure of the second-line treatment strategy. So now we come to the third-line treatment decision-making, and the question is, what should we do in third line? And we have different options, and this leads to question number 3. There are treatment options, for example, to reintroduce FOLFOX, because we know that she responded very well in first line to FOLFOX and never failed FOLFOX because she was progressing in the de-escalate mode without FOLFOX. So FOLFOX reintroduction would be a treatment option. However, an anti-EGF receptor antibody could be an option as monotherapy or alternatively with irinotecan. We know that anti-EGFR with irinotecan works a bit better than as monotherapy, but on the cost of more toxicity. And we know that she, as a pan-RAS wild type, with a pan-RAS wild type status, is very likely to respond somehow, or at least to have stable disease with a third-line anti-EGF receptor antibody. Regorafenib may be a treatment option, but we have to consider that she, as a RAS wild type patient, should undergo treatment with an anti-EGFR before the use of regorafenib, at least on the basis of the published data. And of course, there may be also other treatment options. Our choice in her situation was to continue with an anti-EGFR with irinotecan as the most active treatment, and with her being in perfect health without remarkable toxicity from the first or second line, could still be a candidate for, I would say, slightly intensified third-line treatment. So to comment on this patient has nicely shown that she can be treated with a strategy which we call continuum of care. And continuum of care means we exploit the maximum out of the respective treatment line. We exploit the maximum by using these drugs not necessarily consecutively until progression, but also with de-escalation, maintenance, and the consideration of free introduction as well as the integration of new treatment options. And this underlines how important it is to schedule the treatment options in an optimal way to really use the best out of the evidence we do have of all these drugs and to use all active compounds to the greatest benefit. So with this, I'd like to thank you for participating in this activity on treating colorectal cancer with angiogenesis inhibitors. I hope it will enrich your practice. I would also like to encourage you to participate in the other activities in this series that feature the expert faculty, Dr. Erik van Kutzum, Dr. Richard Goldberg, Dr. Paul Ruff, and Dr. Mark Ishu. Thanks for listening.